Hello, everyone. So, I'll be talking about the importance of perioperative usage of artificial tears in cataract surgery. We do not have any financial interest in the products mentioned in the presentation. So, we know that tear film plays a very important role in the quality of vision. So, after every blink, if the tear film is irregular, there is going to be a gradual increase in your optical aberrations. So, this automatically will decrease the optical quality of an individual. So, as cataract surgeons, why are we worried about this? Because dry eye is predominantly seen in middle aged people. And even after you give a premium IOL and you do a perfect cataract surgery, patients always come back to you saying they have foreign body sensation, irritation in the eye, or they're not very happy with the eyes. So, this could be because of the dry eyes. So, most of the time, we tend to neglect treating dry eye and take care only of choosing the IOL and taking care of that. But then later on, patients always come back complaining. So, what is the impact of cataract on dry eyes? So, usually, when you do a femto assisted surgery, also, the docking itself can cause loss of goblet cells and worsen the tear film. So, that also plays a very important risk factor in patients who already have dry eyes. So, along with this, if you do a cataract surgery with individuals who already have dry eyes, it can aggravate it. It can fluctuate your vision. There can be persistent epithelial defects, and it can also cause abnormal wound healing. So there is a recent article on Journal of Corneal Ocular Surface which says that for the kind of dry eye, say mild, moderate, severe, so in mild evaporative, what do we give? Aqueous deficient, what do we give? And accordingly, what medicine can be given for the kind of dry eye that is persistent. So what was the aim of our study was to compare the efficacy of perioperative versus postoperative use of advanced hydration therapy on ocular surface health in post cataract surgery patients. So the study was done at Narayan Netralaya. So we included all patients who were undergoing cataract surgery above the age of 45 years. We excluded patients who previously were diagnosed to have dry eyes or were if they were on long-term topical steroids. So we divided the groups into two groups. So 64 patients were divided into 32 each. The first group received advanced hydration 2 weeks before surgery and 4 weeks after surgery. So they used it for a duration of 6 weeks, whereas the second group used it only for the post surgery part, that is 4 weeks post surgery. So a detailed dry eye evaluation was done. Cataract surgery was performed, and we followed up these patients on post op day 1 and after 1 month and repeated all the tests again. So we know that the SPEED questionnaire, that is the standardized patient evaluation of dryness, is one of the common questionnaires that we use in evaluating what if the patient's feeling tired in the eye or any gritty sensation. So we score them accordingly. So what we came across, according to the Shermas and TBAT scores, there was an improvement in both the patients, in both the groups, perioperatively and postoperatively. There was a statistically significant improvement in both. But the group 1, which had used the advanced hydration for 6 weeks, showed a slightly better outcomes as compared to the other two groups. Even in the SPEED questionnaire, they were relatively better, both of them, but the group which had used the medicines 2 weeks before surgery had better outcomes. So what was known was that dry eye disease may adversely affect the vision in post cataract surgery patients, and artificial tears containing both HB guar and hyaluronic acid may offer better benefits. But what the study adds is that giving this therapy preoperatively and postoperatively, can help reduce the symptoms of dry eye, and it can also improve the ocular surface health. So to conclude, we found that the combination significantly improved the Shermer score and the TBAT in Group 1. Group 1 patients showed a statistically significant reduction in the frequency and severity of symptoms of dry eye disease as compared to the other group which had used it just postoperatively. And the study also highlights the importance of proper preoperative evaluation and the use of appropriate treatment to ensure the best outcomes for our postoperative patients. Thank you.
Thank you, Dr. Tejal. It was a very nice talk, actually. We keep hearing every time most of the studies come out of for Indian ophthalmology is from Narayan Nethralaya. You have been doing a tremendous job. I think we are just, last time I was part of the refractive meet there. Soon you are also going to get the kit where I think you can really assess the type of the exact cause for the dry eye
Dry eye.
process. As a clinician, like as a general practitioner, patient come to you. So patient come to you with a complaining of with a foreign body sensation. One criteria. Second one, I am having a severe burning sensation. Third one, I am having a very much tiredness. So, what kind of actual eye drops for a general practitioner, apart from all this evaluation done? All three categories also
Yes.
complaints are different, but you found out that they're having a dry eye.
Yes,
So,
yes.
what kind of combination of drops you prefer them?
So right now, advanced hydration is working very well for our patients, especially if they're undergoing cataract surgery,
Yeah.
because it has the combination of hyaluronic acid and HP guar, so it
Mm.
acts really well on these patients. But again, since we can assess the lipid layer and all of these, so there are
So, which
certain
is the brand
medicines.
name? I
This
don't.
is Alcon Sustain Hydration
Yeah, yeah. No, because I've been using that Alcon, one more brand called Systane Complete.
Complete.
Do you have
Yes.
any? What is the difference between Systane? I don't have any financial risk with this particular product. What is the difference between Systane Complete and Systane Hydration?
So both are equally good,
Hmm.
but Sustain Hydration also acts very well on the lipid layer. So
Hmm.
it helps in
But what they
improving.
say that with the Systane Complete, it
It
can take
will.
care of everything.
Yes, sir. We
As a
tried.
general practitioner, love to put only Systane Complete because it should take about every factor in the eye.
Yes, sir. But we have used both Sustain Complete and hydration in our practice, and we found hydration to be slightly better in patients as compared to complete. So we found that hydration was slightly better.
Yeah. Thank you so much
Thank
for
you,
a
sir.
wonderful
It
talk.
was nice having you here, sir. Thank
Yeah, yeah.
you.
Thank you, Tajal. So we'll be starting the instruction course. So quite interesting instruction course. So with most of the consultant is really need this. That is post cataract surgery residual refractory error. I request all our co-instructor to come to the dais. Dr. Rohit Shetty, Dr. Vikram Jain, Dr. Sunil Ganikal, Dr. Chinnappa AG, and Dr. Sharath Hegde to come to the dais. This one. We'll be starting our instruction course, Troubleshooting in Unhappy Cataract Surgery Patient. So here we'll be discussing a important aspect, what exactly the cause for unhappy patient. To start with, we have got Dr. Rohit Shetty, I think he is the chairman of Narayan Nethralaya Group of Eye Hospital, Bangalore. Also, probably as we all know that pioneer in both refractive and dry eye disease. So he'll be talking about the why unhappy patient which is associated with ocular surface disorder. Then I'll be talking about post cataract surgery residual refractive error. We have got Dr. Vikram Jain with us. He'll be talking about what exactly this first top say is. Then followed by Dr. Dan Chinappa, he'll be talking about the decenter IOL and IOL tilt. Then Dr. Sharath Hegde will be talking about why patient will be unhappy because of the associated retinal pathology. In the end, it will be concluded with Dr. Sunil Ganikal. He'll be talking about unhappy patient following a capsular contracture and capsular distension syndrome. Over to you, Dr. Rohit, for your eagerly waiting for your ocular surface disorder.
ಅಲ್ಲಿ ಲೋಡ್ ಮಾಡಿದ್ದ
ಲೋಡ್ ಎಲ್ಲಿ ಮಾಡಿದ್ರು ಬರೋದಿಲ್ಲ, ಇಲ್ಲೇ ಮಾಡಬೇಕು.
ನಾನು ಅದಕ್ಕೆ ಪೆನ್ ಡ್ರೈವ್ ಹಿಡ್ಕೊಂಡು ಓಡಾಡ್ತಾ ಇರ್ತೀನಿ.
ಪಾಪ ಅವಳೆಲ್ಲೋ ಮಾಡ್ಬಂದಿದ್ದ. You can't load it. Load it. Waste ಮಾಡ್ತಾರೆ. After that.
ಅಲ್ಲ, ಅದರ್ ಡೆಸ್ಕ್ ಕ್ಯಾನ್ ಬಿ ಯೂಸ್ಡ್, ಅಲ್ಲಿ ಲೋಡ್ ಮಾಡ್ಬೋದಿತ್ತು. ವಿ ಹ್ಯಾವ್ ಟು ಆಸ್ಕ್ ಹಿಮ್.
I'll be talking first. So I'll be talking about the post-cataract surgery refractive surprise. So a refractive surprise is failure to achieve the intended post-operative refractive target. So what will happen? If it can cause anisometropia, or sometime it may cause dominant switch also. In the end, patient will be very, very unsatisfied. What should be our benchmark? 85% of the eye should be within 1 diopters of refractive surprise. Even more than 55% within 0.5 diopters of target spherical equivalent refraction following the surgery. So always prevention is better than cure. So how we can prevent this? Accurate biometry, A constant optimization, selecting the proper IOL formula, very, very important, and a very important, avoiding wrong lens implantation. So let us come to what are the different causes for post-cataract surgery surprise. So for all this, patient had come to very important subjective refraction is very much essential. Thorough dilated examination has to be done. Always look for a tight corneal suture. See for whether intraocular lens has been placed in the sulcus or is there any subluxation of the intraocular lens. Third, look for distended capsular bag because of the retained viscoelastic, which can also cause a myopic shift postoperatively. And also look for the corneal pathology, like look for corneal scarring, corneal edema. Even that can also influence in refractive outcome. And also look for postoperative cystoid macular edema, which can also cause a hyperopic shift. So I think, of course, let me continue with the cause. Review the refractive history as well as the biometry. What exactly IOL selection process done? Take out your surgical record and find out. Wrong patient biometry, transcription errors, selecting the lens from sometimes by fast when you're doing, you may select the lens from the ACIL column, or even nowadays, even incorrect A constant or incorrect formula. Say one, before going to the next slide, I just want to tell you, same lens from the same company with the 3 different A constant, I had that experience. So I implanted, there was a difference of 2 diopter refractive surprise. Same lens, but different A constant. So you have to be very much, keep it in your mind. So check for the axial length by repeating the biometry. Check for abnormal keratometry, because sometimes presence of high K or high astigmatism can indicating that already pre-existing patient might have had a keratoconus. If there is no error, the refractive surprise can be attributed to the effective lens position, and similar error may occur in the fellow eye also. So you have to be mentally prepared. So let me come to the clinical management of refractive surprise. Explain the patient error, explain openly, and you just tell that this problem has happened. This is not a declaration you are telling the patient that I have done the wrong thing. You are not done intentionally. Sometimes even you can take a second opinion, nothing wrong in that. So normally when you take a second opinion for all these patients, they tend to get a lot of confidence and the patient is going to come back to you only. So what are the options? If you ask me, sometimes doing nothing is the best option. Many refractive surprise do not require any further surgery. Suppose if there is a low myopia remaining, always they'll be very happy for their near vision. Suppose if the patient is already wearing glasses in their career, sometimes when you prescribe them the glasses also, they don't mind wearing glasses. They said that I'm happy with the glasses. So you have to always explain to the patient benefits and risk of further intervention. Also, they should know. So coming to the management part, correcting this surprise depending upon the surgeon and the comfort of the surgeon and the confidence, the IOL, which kind of IOL used, and how long it has been implanted. This is very, very important. Of course, those are with the retained viscoelastic, I think within 1.5 months, the patient come back to you. Even you can do a early laser capsulotomy that can disperse the viscoelastic and allow the anteriorly displaced intraocular lens to move posteriorly. Immediately, patient will be very happy. Coming to the corneal refractive surgery, always not before 3 months. I written here 1 to 3 months, but if you ask me, you have to wait till 3 months for some amount of residual, or you have to wait, give the eye to settle down. Probably PRK or LASIK going to be the best possible options. In terms of optical outcome, both give the similar results. Of course, for older patient, I think I prefer to do PRK than LASIK, because of sometimes LASIK may increase the incidence of dry eye. For younger patient, always I prefer to do a LASIK enhancement. So, what should be the ablation profile? Wavefront guided treatment may provide the better outcome than the conventional LASIK. Lot of studies shows that even one of the study by Genrita et al. What they did, the patient with a multifocal lens with a post refractive surgery, they did a wavefront guided treatment, and the patient did well, very well after the treatment. So there is options. If you do multifocals also, if there is refractor, need not have to become panic. We can correct it with the help of even those are having a examer system with them. So always LASIK seems to be safe in eyes already. The previous yak capsulotomy. Once yak capsulotomy, suppose if you already done, then IOL exchange you can't do it. Once the LASIK, sometimes what will happen, see some certain patients, what I still do in my practice, I know that this whatever you do the best, still there is going to be the refractive surprise whenever you are treating a very high myopia, like you know that posterior cephalomandal. So make it, I tell the patient that I may have to do some last flap before the surgery, put the accurate lens. Still if there is residual error is remaining, then I lift the flap, then I go with the LASIK. So I always keep that option always open. So, what are the limitations for laser vision correction? One is high refractive error, low stromal thickness, and of course, if you don't have examiner system, you have to think of the other modalities. Of course, you have to even from your center spend for this extra cost. There are other options like lens-based option, IOL exchange. So, of course, effective in reducing high degree of whenever there is a high degree of spherical error, the eye election is the best option, and also it will not alter any corneal surface, and there is no requirement of any special setting what we do with the laser setting. Nowadays add-on sulcus lens also available in the market, uh, especially that corrects the manifest refractive error. Power of the original IOL, you need not have to know that, just find out what is remaining, then you can add on piggyback lenses. Even with the phakic option also, piggyback lenses are available. Whatever the residual refractive error remaining, you can implant these piggyback lenses. It come with the very good results. Coming to the add-on lenses, of course, disadvantage sometimes by putting these piggyback lenses, then chances of pigment dispersion also quite high. Patient may come back to a recurrent attack of uveitis, even glaucoma chances also. Slight incidents are high. Coming to the circumflex IOLs, I think I've been doing for a very long period. Some of the patients are already implanted with the monofocal lens. Suddenly they come to us, sir, I want to do when I do have got a laser blazed option of presbyon. Still, they are not fit. I have done with the circumflex trifocal lens, and patients are doing very, very well because of it has got even advantage of intermediate vision. In conclusion, laser vision correction has become shown to be a viable, non-invasive, and accurate procedure to correct emmetropy after cataract extraction with IOL implantation. Lens-based procedure, especially IOL exchange, piggyback lens implantation, are also possible alternative. Piggyback intraocular lens technically easier, more accurate than the IOL exchange. Better indicated in case with the extreme emmetropia, corneal abnormalities, or when there is no available examer platform is available. Thank you so much for the opportunity. Now I request uh, Dr. Rohit Shetty to give the talk on it is associated with ocular surface. Over to you, Dr. Rohit.
Ready?
Yeah.
Ask some questions. There.
Any questions?
Is there a cutoff for the refractive error wherein you choose laser vision or a piggyback lens or a lens-based option over a corneal procedure?
Once again, depending upon how much is the corneal thickness. Suppose, like if you think that okay, up to 5 diopters, we can go up to the PRK option. So you suppose if it is like residual error is around -6, -7, then no worth. In that, best is either piggyback or go for a lens exchange. Once again, depending upon the surgeon confident. Like surgeon like Dr. Chinappa is a fantastic phaco surgeon. You opt for, I think, IOL exchange. Once again, when you're doing IOL exchange, I have seen like I keep telling the people in most of the presentation, they cut into the one half of the IOL, then from the wound they open and they take it. Don't do that. If you want to do IOL exchange, cut the lens into the three piece. That I keep telling. When you're cutting the lens into the three piece with the AC, definitely whatever the endothelial loss is going to be much lesser. Okay, over to you, Dr. Rohit.
Thank you, Dr. Kudlu, sir, and been associated with this IC for such a long time. My talk today is ocular surface and cataract. My colleague, Dr. Tejal, presented the data just before this IC. So I'm going to go a little more deeper into it. I think I see a lot of my friends were part of that meeting also. These are my financial interests. I don't have anything directly linked to it, even though I've done some work with companies which makes dry eye products. So the question is, this is crucial because ocular surface is because the ocular surface disease is more commoner in elderly. It increases after cataract surgery, and Dr. Kudlu sir said that you do a added LASIK on them. It's like a double whammy effect. So you're trying to create more effects on the on your ocular surface. So it's important, along with your biometry and other factors, it's important that slit lamp uh, has to be looked at. Many times this is not taken to too much of into account. As refractive surgeons only, we put a lot of efforts on this. So I'm talking about what a refractive surgeon would do. So it becomes more like a refractive surgeon's aspects. Myopography is not a standard of care and not something which we do regularly. But as we move on, the question is, the cataract surgeries what a lot of you are doing are people who are not the baby boomers. Baby boomers are people who are born after 2000, or who will probably get cataract in the next 5 to 8 years time. These are the old people whose dependence on your the all the hazards of ocular surface was never there. But the next generation who is going to come are your baby boomers getting into cataract and refractive outcomes, and they are the ones who are going to have all this. So we have to be ready to look at it from a refractive point of view. There's a different mechanism to look at the quality of the tear film, even though it's not a very commonly available commercial tool, but it definitely gives you an assessment about the scatter of light from your tear film itself. And people who work on refractive platform or anything to do with uh, on your topographies all understand the role of modulation transfer function, the point spread functions, but this is just from an optical point of view. Let's look at this patient, a 60-year-old a person comes to you for cataract surgeries. Everything is good, your skills are good, your machines are good, and you plan for a cataract surgery. Then suddenly you start looking at it. Then you start asking them, in your staining, there's diffuse staining. We give them, try to build the scoring. The ocular surface disease index score is bad. There's meibomian gland dropout, and your epithelial mapping is completely irregular. And if you have access to non-contact debut, it's also not very perfect. So one thing, but this lot of us would not put in too much emphasis because this is just a cataract surgery. I'm not touching the ocular surface here, and you would probably want to do a procedure. There comes all your phantoms, and that's where my talk is today, is to understand these phantoms, because this is a typical case which comes to you and who gets it done. I just presented this in ASCRS just a few days back, and next to me was Damien Gatinil, and he was telling me that that scenario is resembles his mom, on whom he operated his cataract, and she just complains bitterly about the pain and ocular surface issues. So I mean, he's a refractive surgeon. So what really happens, and why do we get this complaints? There are two important things out here. One, when you start digging deeper, that's why I call it the phantoms of thinks phantoms is something, the ghost who walks and you don't see. And here the phantoms is what you don't see. When you look at your nerves, these are, a lot of them have this microneuromas. Many of them have this inflammatory cells in your cornea, which is closer to the nerves, called dendritic cells. Now, what do? These phantoms are mostly quieter. They don't really bother. But you do your cataract surgery, the microscopic light is quite toxic on all of them, because the cells of a body behaves differently to different colors of light. If I use a blue light, it behaves differently, red light. When you use this and the povidone iodine, the anesthetic drops can, these are all sleeping, it's like sleeping, ghosts. Minute you trigger them, they start firing. And what happens to you? What happens to this patient? Cataract has gone on very well, but the patient says that I can't put water into my eyes, it hurts. And this is after 1 year. And somebody speaks very loudly, my eye starts watering. And you just try to push them away because you think this is not normal. It's all normal. This is all misrouting of the nerve fibers. And whatever drop you give them, it doesn't work because lubricants, steroids don't work on this. So, what really happens in these cells is what we wanted to study. There are two types of cells. Keep looking at these cells. These are normal cells. Every time a normal cell dies, the cells next to it eats it up. It gulps it. And that is what happens in every single cell of your body. And that is called autophagy. It is nothing but cell cleaning itself. That means your eye has to clean itself of the dead cell. You create an environment something similar to a post cataract situation. It is not able to swallow, nor it's able to digest. It just builds up. When you build up, that secretes all kinds of products which you don't want. The reason I use the word civilized cells, stress cells, word civilized cells is what I coined for it, because the word civilization came in for human beings, for humanity, the day one human being started taking care of the other. And that's why we call civilized. And this is about one cell taking care of the other. So, how does it affect? In a cataract, LASIK, or anything, a healthy cells which takes care of the others has a good epithelium, nerves are healthy, ocular surface inflammation is not there. Minute you have this, you have poor epithelial irregularity, nerves are unhappy, everything becomes completely off. So, how does these cells respond to therapies? And that's where we brought in the concept of making the cells to work. And this is why one of my favorite drugs, I have no financial interest, unfortunately, is the Trehalose, because it creates an environment post surgery to make those cells back to function. And how does it make them back to function? This is these orange ones are like your gut enzymes. They digest dead cells. When you create a dry eye scenario, something similar to cataract, microscopic light, LASIK, cells can't function. There's no orange enzymes. Minute you use those drops, the enzymes, you can see them so beautifully. It can, and what it does, it makes the same cell to regenerate, reignite. So that's the power of using the right molecules. And the second part of my work has been looking at all these molecules from the tears. It took a long time for us to come to a stage where we are using uh, our own. This is the only machine, we have a patent on it. No other, this is a machine which is designed by us, where you can check the entire biomarker profile of your tears. And what are those markers profile? They are the ones which makes your patient happy, are the ones which does not make your patient happy. And this is what I've already shown here. So the question was, how do we study from the tears? And at this point of time, to make a story quicker, in the interest of time, we have these markers, we have this normal. This is what Dr. Kudlu asked Dr. Tejal just a few minutes back. It's just all there, all the culprits which can cause different things. For example, a patient comes to you with eye irritation. It could be one of these factors. Your epithelium keeps becoming recurrent erosion syndrome. It could be IL-17. The patient has more pain than what you see. It could be MMP9. The patient has chronic irritation and you don't respond to treatment. It could be one of those molecules. And how does all of them help you? Then we build an AI to it. And in the AI platform, we look at this is what happens in your cataract patients. This is what you operate. 90% of them have such high level of information without being using contact lens or anything, that they're just a blessing to us that most of them don't complain, because that's how elderly patients are. They don't complain, but at some point of time, all the younger people are going to come to you. And this is exactly what I said. All your cataract patients you operate on are filled with all kinds of inflammatory cells, which just means that your ocular surface response has to be very clearly monitored. And how does it really help you? Why do you need to monitor? You say that my patients don't have a problem, I don't need to give them any lubricating drops and all that. But the subclinical information keeps changing, and they are responsible for many things: recurrent erosions, unhappy eating, and multiple other factors. So in the future, what we are looking at is the same set of reports. Now you can choose the drug you want, because one drug which works on ICAM1 intracellular adhesion molecules will not probably, oops, somebody, it looks like, okay, somebody else was handling it. So it was the same thing may not work for the other molecules. So targeted delivery system is going to be the way to go, because now whatever, it's like saying that irrespective of what your antibiotic sensitivity is, I will just use moxifloxacin for all my patients. That's exactly what we are doing. We don't even know. If you don't culture it, you will never know what is sensitive, how the bacteria work. This is like the culture report of your entire immune profile of your eye, and all the molecules you're using now, cyclosporin, tacrolimus, liftigras, trehalose, everything acts on one of those molecules. And it's important that the future, I mean, this is what we started doing it in a clinic now. We titrate based on what we are getting. Liftigras is still not available, but in US you call it as Zedra. You have, if you have a bunch of molecules which are very high, we can choose it. So there is a beautiful way of customizing your ocular surface before surgery or after surgery when your patients has these problems. I've explained about all this in the past. The challenge for you is about, if your ocular surface is bad, your IOL formula is bad, quality of life now has got more importance than just the quality of vision. Everywhere, all the papers coming out today is about quality of life, and we have to be very careful about that. And look at this, just a astigmatism. Somebody wants to put a spherical aberration EDOF lenses. Imagine if your cornea has such high level of higher order aberrations. My colleague would say, I would not want to put a EDOF, I would not want to put a multifocal. Why? Because your cornea has an aberration of 0.4, because 0.3, there's a unwritten rule somewhere that 0.3, more than that is, you shouldn't use it. But minute you use lubrication, the aberration disappears. But you would have denied this patient a chance to put the best lenses. You'd have just put a monofocal lenses for him. And this is just a typical example of how your quality of vision changes with this. Of course, there are a lot of new therapies now, LipiFlow, LipiView, and all these procedural therapies help to make it more faster. And one important thing which I want everybody to take home today is your ocular surface, poor before or after surgery, has a huge impact on your toric lenses, because toricity is also dependent on the epithelium. If your epithelium is irregular, the epithelium itself is giving you 0.5 to 0.75 cylinder. The MS39 from CSO gives you a very beautiful cylinder only from the epithelium. So that's how we started understanding. And now, if the epithelium in this case might be close to around, in this case, it might be around close to around one diopters. So if you do a toric lenses and your ocular surface is not taken care of, after a year, the patient may end up with a toric lenses of some 0.5, 0.75, some axis. and you are worried that how did this happen, because I have put the perfect one. Then you think about whether I have my axis is right or this is right. But the question is, everything is proper. The issue is that your ocular surface is not taken care of, and epithelium is a surrogate marker of your ocular surface health. So the last thing is very important. This is a work done by Dr. Bhavya and Dr. Reshma, who was helping me out here. Is about patient comes to you with vague symptoms, and all these vague symptoms, we call it as dry eye, and everybody is pumped with gallons of whatever lubricants you want to pump, which keeps the companies happy. But one of the major challenges is, if you put this Venn diagram, the ocular pain, fatigue, blurry vision changes, feeling of tiredness is also linked a lot to binocular single vision. And binocular single vision, patients will not come and tell you that I'm having difficulty to focus, or if you have a difficulty to focus, we'll definitely look at it. But they have vague complaints, and one of the issues was the nexus of ocular motility and dry eye. And a lot of these patients have fusional issues, convergence issues. So before you label a patient a failure to your treatment, make sure that you pick up one good optometrist, or you train yourself, or ask somebody to learn the proper way of looking at orthoptics evaluation. And this whole nexus, we call it nexus of ocular motility, accommodation, and dry eye, is one of the most common issues we see in younger patients on whom you do your EDOF, multifocals, and all these lenses, because they just confuse, especially hyperopes, mild hyperopes, on whom your previously, if they were hyperopes. So remember this, the motility issue is one of the biggest phantoms in ocular surface disorders. And most of the time, they just go multiple places, and just a good exercise, or informing them that you need a proper ergonomic change, would probably help them into this. This is a classic example of patients who had the same thing, and look at his OSDI was high, Shermer's was 25, but T-but was no. Everybody looked at T-but, because T-but is a low-hanging fruit, because everything it's a culprit for everything. But minute OSDI was very high, that means the patient had a lot of symptoms, and he was not responding to treatment with whatever we gave him. And the biomarker test, what we did, showed that he had hardly any inflammation. That means that the problem lies somewhere else. And then when we looked at it, he had divergence insufficiency, but he did not know how to express himself. And when we gave him those exercises and all those factors, he just completely became normal. And he's been with us for a long time, and this is just one of those cases, and most of them get better within 1 week of exercise. So my take home point is, ocular surface is not something which you can assume that it comes to once somebody who's very fussy, or once in a while. It happens. A lot of your patients are good sufferers. They suffer without actually complaining. And time is not going to be always on our side. When all the good sufferers kind of patients, we are going to meet them more often. We're going to have patients who are going to have problems with even the smallest of issues. And dry eye may exist in spite of not having symptoms. That's the most important thing. That's the biggest phantom. Optimization of ocular surface will come, and that kit is there. But now, Trehalose, cyclosporin, these are the medication you need to use much early, because cyclosporin changes the entire ocular surface milieu. And post-operative dry eye is one of the most badly managed thing. When I keep discussing this with all my colleagues, we as refractive surgeons, we are so aggressive on the post-op dry eye. From the day one, we start on cycle, because we know how aggressive the wound healing would be. But many times, cataract surgeons are very shy about starting on cyclosporin. Half the time, the therapies are not advised. I feel that the time, you've been lucky, because our patients are good sufferers. They don't complain. But let's not wait for the ones who will create a challenge for us. So let's be more aggressive in this management. I thank Dr. Kudlu and all my dear friends in this panel for this opportunity. Thank you.
Thank you, Dr. Rohit. So your take-home message, what you feel that I think Every cataract patient, I think before surgery, we have to do a dry eye workup.
You don't need to do a complete one. See, just look at his lids, look at his meibomian glands, and if you have an epithelial map, do the epithelial map. If the epithelial map have multiple irregularities, you know this patient is going to have a very bad ocular surface. Epithelial map can be used for cataract surgeons also. Irregular epithelial map will also give you a very irregular biometry, and especially if you're doing a cylindrical toric lens corrections, it's not going to be the same. So anyway, you have an epithelial a mapper. Why not use? I mean, economically also it will give you rewards.
So once you do all this investigation, we know that patient has got having a ocular surface disease. So you have got a gauges of treatment, like you can got a therapy like eyelid therapy and with the drops. So how long we have to do the treatment and also drops, then to take them for cataract surgery?
If you're doing, it's with a very bad ocular surface, if you do any therapy on them, give at least 10 days time, because minute you do any of eyelid therapy, it's a pseudo increase of inflammation. Lot of times people do a therapy and next day morning they post them for cataract. Your eye is heavily inflamed, and your minute you do, you may end up in more challenges like mild uveitis or infiltrates and other things. Give 10 days time. Even though you've done a therapy, it reduces after 10 days.
And then when you can start, you have been telling that the products like Trialus and cyclosporin, it very much useful, especially this post-operative dry eye. So can we start very next day of the cataract surgery?
Absolutely. See, the question is, many places in the world has a protocol that they start cyclosporin at least 2 or 3 weeks before cataract surgeries.
Oh,
So, especially, you go to US, it's one of the most prescribed drop preoperatively, and they continue for 3 months, especially when you have meibomian gland dropout. So, what you do is, in premium cases, little bit extra. I mean, just a meibography, just an epithelial map might help you, and see, it also makes you more, I would say, a more thinking surgeon. You are more and more careful about everything, and like how you do it for your refractive patients.
thank you, Dr. Rohit. I think for eye opener talk. Let us go continue with the other talk by Dr. Chinnappa. So he'll be talking about the decentered IO, decentered IOL and the tilt. Over to you, Dr. Chinnappa.
Good evening, everybody. I thank Dr. Kudlu for having me on his team for this course. Now we saw this mind-blowing talk by Dr. Rohit Shetty about what happens on the surface that makes the patient unhappy after the surgery. Now we go into the eye and try to deal with some problems that happen on the IOL level, which we fail to identify at times. Decentration means there is a defect in the XY axis of the IOL, and tilt means there is some movement on the Z axis of the IOL. So most of the times, even after having uneventful cataract surgery, when the patient comes back, you have a 6 by 6, and still the patient is not unhappy about the quality of vision. We usually tend to dwell a lot about the surface of the cornea rather than going and looking if there is some problem with the IOL itself, because you haven't had any problem with the surgery. It was uneventful. It looks pristine, and but there could be times when there would be small decentrations and small tilts, which could actually be the cause for the unhappiness or the blurry vision the patient has. So up to 0.2 to 1.8% of patients after cataract surgery can have IOL tilt. So with the present advancement in instrumentation and techniques, I'm sure it's more towards the 0.2% than the 1.8%. But still, there are cases where we encounter decentrations and tilts. So intraoperatively, the most important cause for decentration, which we could avoid, is a very large rhexis. So having a rhexis overlap of about 1.1 mm all round circumferentially on the IOL, it has been stressed upon, but we all try to achieve it, but we can't fool ourselves, because it is not absolutely a repeatable thing. There could be times wherein even after we try our best, there could be a rhexis which is not overlapping the IOL, and this could cause a decentration in the postoperative period. Zonular weakness, anything more than one quadrant, could cause a decentration. Haptics being broken or kinked. Yes, you inject the IOL and the trailing haptic gets caught in the injector. Which you somehow fight with the IOL, get it out, and you don't have the heart to actually explant the IOL and put in a new one. At this point of time, what we do is we tend to do kind of a cover up, and we think and hope and pray that the IOL won't be decentered. Even if it is decentered, we don't want it to be causing harm to the patient or symptoms to the patient. But sometimes it could. So it could happen intraoperatively or 1 or 2 days or few days after the surgery, but usually we don't see the patient few days after the surgery. Even if the patient calls you and says the patient, I don't have very good vision, you over the phone, you would want to comfort the patient and say, we'll wait for a few days, it could get better. But if you would have left visco in the bag in a toric IOL, it could have caused a rotation of the toric IOL. And if there is a distension of the bag, it could have caused a tilt of the IOL, that is an anterior posterior tilt, because as less as 5 degrees of tilt can cause some amount of blurring. So, and then there could be secondary causes which could be patient based, which can happen way later than the few weeks or days that I was describing. Like I said, a millimeter of decentration can also cause symptoms, especially in aspheric IOLs. So aspheric IOLs, the dictum is you need to have the apex of the cornea in center to the center of the lens. If that axis is moved even by a millimeter, it can cause some amount of symptoms. So in a spherical IOL, it doesn't happen as it's not as bad as in an aspheric IOL. And then I mentioned any degree of tilt in the z axis, an anterior posterior tilt can cause an unhappy patient later. So effect of pupil size, yes. So not all patients have the same pupil size. Anything as a patient with a 2 mm pupil size, you could get away with no symptoms. But anything beyond 3.5 mm, especially in a mesopic condition, patient will say, I was sitting in a restaurant or sitting in a movie. When I go sit in a movie, the things are not very clear, but I'm out in the sun, I'm up and about. So that is something that you need to assess and see whether the cause is on the lens. So you can actually grade the lens decentration by mild, moderate, subluxated, and dislocated, but it doesn't matter because the management of the decentered IOL doesn't really depend on that. So what symptoms could the decentered IOL cause? A decreased visual acuity. If it is a toric, definitely. If it is rotated, it could cause decreased visual acuity and induced astigmatism. Glare. If the edge of the IOL is at the or within the edge of the pupil, then that can cause glare and monocular diplopia. If there is a clear zone between the edge of the pupil and the edge of the pupil and the edge of the lens. Floater-like symptoms, yes. If you've had a PCR and if you've convinced yourself you've done a good job, but still there is some amount of vitreous incarceration at the edge of the IOL, that could cause floater-like symptoms. And if it is completely completely luxated into the vitreous cavity, of course, then that's a whole different ball game altogether. So there are multiple methods which we can use to actually measure. Purkinje imaging technique is like if you see the third Purkinje image, which is blurry, that means there is some amount of decentration. So you can use the Purkinje imaging system over your slit lamp itself, but it is almost void because you have much better techniques to actually do this. You have a scheme-flug imaging techniques. These give you almost a perfect assessment whether it is a decentration or a tilt that is causing an unhappy patient, or if the IOL is pristinely placed within the bag exactly how you want it to be. So this, some of the latest equipments could actually give you a measurement by itself, and now you don't need to do it manually. Here, and basically what you're trying to see is if you're assuming that the anterior surface of the iris as the horizontal axis, and with that as a standard, you see whether the anterior surface of the IOL is exactly parallel to it. If there is anything beyond 5 degrees, like I mentioned, that means there is a tilt of the IOL, and that should be addressed. How it should be addressed, I will come there soon. AIOCT, yes, again a great tool to actually measure tilts. Here you can see that the IOL actually has tilted about almost about 250, almost about 150 microns, which is a huge tilt. Here you can actually visualize that the IOL one haptic is probably in the sulcus and the other in the bag. But the problem with ASOCT is that if the pupil is non-dilating, you can't actually whatever is behind the pupil. So eye trace aberrometry, yes, I mean, I don't think I should talk anything about the cornea here, because Dr. Shetty has already spoken in detail about it. Basically, eye trace, what it does is it separates the aberration that comes from the cornea and the internal aberrations. That's why it's so important, because once if you do a topography and see that the cornea is absolutely okay, still, like, you see that the patient is unhappy with glare and halos or starbursts, then you might have to see whether the IOL is the one that is causing the aberrations. And here you can see the higher order aberrations can actually directly be measured and seen that, like, here you can see that the coma and the trefoil are extremely high in this case, although the surgery was picture perfect. So and, like, if you ask me what do we do about this, I mean, not much, because, like, we couldn't really find a cause as to how, I mean, exactly what's the reason. It could be a manufacturing defect of the IOL, before all you know. So IOL dislocation management, yes, I mean, IOL dislocation is when there is a very gross decentration or a tilt, or if a part of the IOL is in the vitreous or in the anterior chamber. So that could definitely cause way bigger problems than a 6x6 patient. So, I mean, that's not really a topic that we need to touch on here. So when do you actually correct the decentration? If you diagnose the decentration, is at least about 2 weeks after the first surgery, anytime after 2 weeks after the first surgery. So if you think that the bag sublux is the cause, then you put in a CTR and hope it could be corrected. But the problem with these techniques is, like, there is no absolute guarantee that you can give to the patient about the outcome of the second procedure. So you also have to, like, I mean, Dr. Sharath will be talking about macular function and other things, but you always have to keep in mind that when you as a lens surgeon, you have to have a multidisciplinary approach when we try and tackle patients who are unhappy even after a 6x6. So IOL repositioning usually done if one of the haptic is in the bag, or if the damaged haptic is the one that is causing the decentration, you could position the IOL, or you could remove and exchange it with another IOL. So anterior vitrectomy, yes, like, in cases wherein, I mean, you place the IOL in the sulcus, but there could be a small wick which is actually causing the decentration, then you do do a vitrectomy to reposition it back into place. So IOL exchange, yes, IOL exchange is I mean, most commonly required when you've seen, or you've been overconfident about or over enthusiastic about not changing the IOL on table even after detecting a haptic cut. In such patients, you always have to keep in mind a lot of other things, surgical nuances. And in some patients, what happens is, like, if the patient absolutely disagrees to go for an IOL exchange, a pupilloplasty could also be an option. So that could actually, I mean, could be a less invasive option. We have done it in 1 or 2 cases, and patients are relatively better after the surgery. Thank you very much.
Thank you, Dr. Chinappa. I think the take-home message, if suppose patient is already having the tilt and or decentration, so can we do it immediately or can we do it later on? Because see, we have to, certain study shows that some amount of patient glare and hair loss, we give time for neural adaptation also. Certain patient just get adjusted with that, because always second surgery is always second surgery when you do that. So can we able to give them the option for neural adaptation, or straight away go after a couple of weeks of surgery?
Absolutely. Best case scenario is not to take the patient up for a second surgery, like you said. But like Dr. Shetty was saying, about quality of life. Now when people talk about quality of life, and if something is bothering them, it is like a thorn under your nail, I mean, they keep coming back to you. You might rather take the radical decision of going in and operating than keeping it there and expecting, like, that same patient, same unhappy face, sitting outside your waiting room. It's not a very comfortable sight to have those patients keep coming back to you.
One big challenge which all of us are going to face is when there is a transition from, say, the plano lenses, the aspheric lenses, now the EDOF.
Yeah.
See, EDOF is heavily based on how your spherical aberration coordinates to your cornea and how it balances or how it adds up. A small change in your tilt or the way the lens is positioned is going to be very, very less forgiving than what it used to happen in the past. So your talk today really emphasized the importance of it, but it's going to be maybe a millionfold important with the new lenses.
Yeah, but then I think we are kind of using EDOFs uh, a bit more aggressively than we should, because not all patients are taken up for spherical aberration profile before taking up an EDOF. We are assuming that the spherical aberration profile is okay, and then, like, advise EDOF for everybody. But then there are certain patients who come back and say that you promised us about intermediate vision, but our distance itself is compromised. I mean, that is because there is a conflict between the spherical aberration on the cornea and what you're giving on the lens.
Yeah, thank you, Dr. Chenappa. In fact, pre-op evaluation is very, very important. So just going ahead with that, so what might be the other reason for unhappy patient? Dr. Vikram Jain will be talking about dysphotopsia. Dr. Vikram.
Thank you, Dr. Kudlu. Thanks for this opportunity. Dysphotopsia is when your patient has very good vision, but he's still unsatisfied because he is seeing more than 6.6. What is he seeing? I'm not talking about the glare that the halos that you expect with multifocals, because this you already know about, and you would have counseled the patient that initial period these halos will be there. There are a multitude of other problems like glare, starburst, flare, and all, which can be seen by the patient, and this will make the patient unhappy. So you have positive as well as negative dysphotopsia. Positive come in the form of bright light, in the form of arcs or streaks. Negative is a temporal dark shadow that most of our patients always complain about. There are no objective tests for this dysphotopsia. It's always based on the patient complaint. And remember, you should always distinguish this dysphotopsia from vitreous traction, the retinal vitreous traction, as well as a linear streak if there is a linear streak in the posterior capsule which is causing the Maddox rod effect. So distinguish this from a positive dysphotopsia. So positive dysphotopsias, as I mentioned, can be an arc, a central flash, or a flare. Arc is when the patient perceives the edge of an IOL in a scotopic pupil. It generally resolves over time as the peripheral capsule opacifies. Flare is caused by a small cylinder or a coma remaining. Correcting this small cylinder with his spectacles will resolve this. And also putting pilocarpine, especially in the afternoon, so that evening his pupil is smaller in the initial days, will help in reducing these symptoms. Central flash, sometimes the patients complain about. This is because of a total internal reflection at the edge of the IOL. Again, the IOL manufacturers have made changes to the square edge lenses to reduce this. So here what's happening is that light is coming, hitting the peripheral edge, which is getting reflected inside, causing this central flash. Starbursts are when a backscatter from the surface of the lens cause multiple small spots in their vision. So these positive dysphotopsia are more common in square edge IOLs. Earlier there were some IOLs with an oval optic. Again, these had more positive dysphotopsia, and also IOLs with a very high refractive index like an Alcon IQ. So changes made by the manufacturers are from the square edge, rounding of the anterior edge. This makes sure that there is no much internal reflection, total internal reflection happening there. The light just gets scattered. As long as it's not totally internally reflected, this edge glare won't be there. And also decrease in the thickness at the periphery compared to this Here, if you see, it's a lenticular design. In the periphery, the thickness, when it's decreased, these changes have been incorporated by most manufacturers over the past 10 years or so, and therefore these positive dysphotopsia are rarely seen in patients now. Correcting any refractive error and ocular surface disease, as Dr. Rohit mentioned, are very important. These can also give rise to these symptoms. If there is any posterior capsular opacification, even in the early stage, if this can cause some blurring, and all these symptoms can get magnified. In the initial days, pharmacological meiosis, if you prescribe pilocarpine in the afternoon hours, so that in the evening when they get out, the pupil is smaller, limited to 3 millimeter or so. Therefore, these positive dysphotopsia won't be there. In case if it's an IOL problem itself, then the IOL has to be exchanged. Coming to the more difficult to solve negative dysphotopsia. Here, the patient complains of a dark temporal shadow in the periphery. It's an arc-like image. Initially, around 1/3 of the patients complain about this. Later, within a year's time, this naturally settles down. It is seen most commonly on the temporal side, and more than 75% of the patients who complain about this negative shadow, it's always in the temporal. This is probably because the nasal retina extends more anterior, as well as light coming from the temporal side is not blocked off like in the nasal side. This is always associated with a IOL which is totally in the bag. It is not seen if the IOL is in the sulcus or partially if one haptic is outside. It can occur with any IOL and incision in any location. Basically, it's an anatomically perfect surgery. If it's anatomically imperfect, the patients don't get negative dysphotopsia. So negative dysphotopsia means that you have done a very good job, but the patient will complain about this. It's more common in higher powered IOLs. This is how a patient would typically describe it. In this patient, if the left eye has been operated, on the temporal aspect on the left side, the dark shadow is there in his vision. There are two schools of thought for this. Holliday said it's the edge penumbra because there is some varying refraction of rays, some area which will cause the negative dysphotopsia, dark shadow there. This was countered saying that it still occurs with the round edge where the scatter is a little more, and therefore there is no dark area. The other theory is that it's because of the position of the IOL, the effective lens position. When it is more posterior, there is going to be a gap between the pupillary margin as well as the IOL, wherein rays of light can pass unrefracted. Through the IOL, they would pass refracted. The rays in the more periphery would go in directly to the periphery of the retina. So in between, there will be an area which is not receiving any light, therefore causing this temporal dark shadow. So here you have unrefracted light directly going in. The ones which are hitting the periphery of the IOL are getting refracted and going there. In between this area would be the dark shadow. Surgical management, if necessary, would involve putting a piggyback IOL in the sulcus so that this problem of unrefracted rays is not there. You're going to be blocking off some rays in between them, or doing a reverse optic capture by getting the optic of the IOL into the sulcus, or repositioning the entire IOL in the sulcus. There were certain IOLs which were described known as a dysphotopsia IOL, wherein you're supposed to tuck the anterior capsule into the ridge of the IOL. However, most of the time, just masterly inactivity does the best job. In the initial slide, I told you at the end of 1 year, it's from 30%, it becomes only 3%. We all don't see our physiological blind spot. We don't perceive the retinal blood vessels. Our cortex generally learns to suppress this over time. So masterly inactivity is the key in most cases. Only around 2 to 3% would still complain of them. This we have to handle with care. Explain to the patient that it might go off later. Basically, doing nothing solves this problem. You've already done an anatomically perfect surgery. Therefore, it would settle down. Thank you.
Thank you, Dr. Vikram. I think most of the complaint, I think most of us do agree here, especially for negative dysphotopsia with the arc around.
Yes.
They keep telling there is arc around, what to do. So I think you have to keep assuring them. And any other drops will really help?
Placebo effect. We would still give them a thicker lubricant or something. The placebo effect, when they see it going off, they'll think it's because of the drop. They'll continue the drop for 3 months, it will go off, and he's happy, you're happy.
with some antioxidant also.
Some placebo, yes.
Yeah. Thank you so much, Dr. Vikram.
Thank you.
We'll go. Any corneal treatment can help.
Not that I know of, no.
So let us go to the next talk. Why unhappy patient? Because of the capsular contracture and distension syndrome.
Good
Over to you,
afternoon.
Dr. Sunil Ganikal.
Good afternoon, everyone. Today I will be talking to you two common most problems one faces post cataract surgery. One is a capsular contracture, other is a capsular distension syndrome. When you plan for cataract surgery, as we know, we want a perfectly centered IOL with no IOL tilt or decentration. You want a perfect optical quality or a pristine optical quality. That's what an optimal result one expects. See, anterior capsular contracture and the shrinkage usually occurs much earlier than the PCO. The capsular contracture basically occurs because of the anterior cuboidal lens epithelial cells metaplasia, which causes fibrosis and the contracture. So, how to diagnose a capsular contracture? One, by examining under direct visualization under slit lamp. Look for any change in the IOL positioning and the result in the shift of the any resultant and refractive shift post cataract surgery. One should suspect a capsular contracture. Why one should worry about the capsular contracture is obscures the vision, affects the IOL position and function. The progressive contracture can sometimes lead to IOL capsular back dislocation. More important especially in premium IOLs, especially presbyopic correcting IOL, you've done a good surgery with multifocals and trifocals. Due to capsular contracture, one may face a problem. And best form of prevention in these cases is follow-up of high-risk cases. I'll tell you what are all the high-risk patients one need to follow up in this. What are the predisposing risk factors one should look into, in especially those who are prone for capsular contracture? Is one is, of course, pseudo exfoliation, uveitic patients, retinal degenerative conditions, high myopia, advanced stage, subtle zonular damage due to previous surgeries. It could be trabeculectomy or vitrectomy, diabetics. So all these patients are prone for capsular contracture. A large capsular rhexis does not eliminate the contraction effect, but the only thing is it assures that in spite of contraction, you will have a clear-cut central zone, so you will get away with that. So never leave a patient with a small rhexis, so it obscures the optical quality. So removing the anterior lens epithelial cells sometimes may help in prevention of PCO, but how far it helps in preventing the contracture is doubtful. But difficult in obviously when there is a zonular weakness is there, the polishing of anterior capsule may further damage the zonules and can hamper the surgical results. So one should be very careful with the patients with zonular dissense or weakness. So IOL design and materials, it has been shown in studies that capsular contractions are more seen with silicon plate IOLs, silicon optic IOLs when compared to the acrylic optic IOLs. Prolin haptics tends to cause more optic capture than the PMMA ones. Whether the single piece or three piece, the variable results, different study shows different thing. Square edge lens, not much effective, unlike in prevention of the PCO. So one should be very careful when planning, especially when in a presbyopic IOLs or multifocal IOLs. CTRs, definitely in spite of CTRs in high-risk cases, people have found decentration due to contracture and other things. So in high-risk cases, I prefer to, especially in cases with pseudo-exfoliation, the reports have been there. In spite of using CTRs, IOL back dislocation has been reported. So one need to suture CTR sometimes in high-risk cases to prevent the contractures or prevention of dislocations. Especially sutured, you should use a sutured CTR or CT segments in high-risk patients. See, this is a typical case because of the anterior capsular contraction. The AC depth is the markedly thickened anterior capsule. IOL remains in the capsule, but you can see the posterior vault because of the capsular contracture. So, in such scenarios, the simplest solution being doing an anterior YAG capsulotomy. How to do it? You can do a 4 symmetrical incisions you can put at the capsular rim, so that it causes the relaxation. Start at the edge of the capsular axis and extend it towards the periphery. Incision over the IOL haptic should be avoided to prevent the symmetrical asymmetrical lens tilting. So anterior capsulotomy is a simple procedure by which you can get it off. So once you do that, you can clearly see that the hyperopic shift what we had because of the lens vault, it is reduced. So it is one of the simple and effective methods of treatment. Suppose if the fibrosis is too thick and it is involving the obscuring the visual axis also, not amenable for laser also, you have to move on to the surgical maneuvers. You have to do a bimanual techniques. You should not pull it because the pulling may sometimes dislocate the whole, pull the zonular damage and cause a IOL capsular decentration. So closely, gently hold that and make a nix in the center of the capsule. Then using a curved scissors, preferably 23 gauge long lengthy scissors, one can do, taking a pupil as a reference mark. You can go all around and increase the size of your capsular axis. So this is the indicated when there is a severe fibrosis which is not amenable to NDAG laser capsulotomy. We can do the surgical maneuver by which you can open the anterior capsule to a larger extent. Of course, one if he has got an access to femto laser, you can use an femto laser also to give a relaxing incision to the anterior capsule so that you can get away with your capsular contracture. Here the laser being applied, femto laser being applied. This is another method one can adapt. So what are the preparations and actions in a capsular contraction? So one is a vigilant observation, especially in high-risk cases. Select the appropriate IOL. Consideration of CTR and segments usually should be combined with sutures. So meticulous surgery with capsular cleaning should be followed up. Laser, that is AIOC laser or surgery or multimodal combined approaches should be used in patients with capsular contracture syndrome. Now moving on to the second problem one tends to face is a capsular bag distension syndrome. It's a rare complications. You tend to see a presence of a turbid fluid like this between the IOL and the posterior capsule. It could be either intraoperative, early or late postoperative. See, early postoperative invariably it is due to retained viscoelastic, and late is because of the incomplete removal of cortical sense and fibrotic changes. So why we should differentiate between each one is the pathology is quite different. If it is a fibrotic, the management is different. Typically tend to see in the late postoperative inflammatory, it does respond to anti-inflammatory drugs. And if it is a retained OVD or a viscoelastic, we need to just wait and watch, and sometimes the OVD can be washed off. Similarly, there are another classification of capsular bag distension syndrome based upon whether the transparent fluid is there or a turbid fluid is there. What is the status of the PC, whether it is transparent, PCO, or presence of Sommering ring. So some of the differential diagnosis one should know: when you see an opaque turbid fluid in the IOL, it may mimic like a phacoanaphylactic uveitis. Dense PCO sometimes can mimic like this. Propionibacterium acne chronic endophthalmitis sometimes can have a severe plaque and can mimic like a capsular distension syndrome. The pupillary glaucoma, and nowadays with the newer hydrophilic calcified IOLs, we tend to see many such from one of the companies which tends to mimic like a capsular bag distension syndrome. The imaging modalities, definitely yes, anterior segment and UBM both can be used, and even the Schlempfeck imaging. UBM is superior when the capsular bag is very well distended. You can see the much better than the anterior segment OCT. So how to treat this capsular bag distension? If it is asymptomatic, you can observe. If it is an inflammatory pathology, you can add an anti-inflammatory drug. Of course, anterior capsulotomy does help, but the problem with anterior capsulotomy is once you open the PC, this turbid material, once it enters the vitreous cavity, can in some patients may induce a vitritis or a severe inflammation. So you need to closely monitor if you do a blind NDI capsulotomy or opening of the PC. In the surgical maneuvers, definitely you can do a needling maneuvers to open up and through the anterior capsule and drain the fluid. Then there is an anterior chamber aspiration, but if it doesn't respond to any of those things, you can go via pars plana route and open up the PC and aspirate whatever the fluid present between the IOL and the PC. So what are the advantages of pars plana vitrectomy over compared to the NDI capsulotomy? As I told before, one, you can get the fluid for microbiological evaluation, whether to rule out whether it's an inflammation or an infection. The other thing is it avoids the fluid getting into the vitreous cavity, which reduces the chances of inflammation and other things. So this is the pre and post treatment after opening the PC. Similarly, suppose if you feel like PC is very clear, if you don't want to do a NDI capsulotomy, we can make a small peripheral iridotomy and with that open an anterior capsule so the fluid leaks into the anterior chamber and you can just do an AC wash. So if you want to still preserve the PC in some other cases, you can follow this. Of course, NDI posterior capsular opening, it is a routine YAG capsulotomy. Once you do that, you can get rid of this capsular bag distension syndrome. Sometimes what happens is there is an adhesion between the capsular margin and the IOL, which keeps the turbid fluid between the IOL and the capsular bag. Just releasing that adhesion between the capsular excess margin and the IOL will allows the fluid to come into the anterior chamber. You can easily aspirate that fluid. This is one of the maneuvers we can do it, and just tap the IOL, whatever the liquid is there, which will come into the AC, and you can get rid of this capsular distension syndrome problem. Yeah, all the fluid comes out once you tap the IOL. Thank you for your patient hearing. So this is a simple thing. One should know how to tackle it and rule out what are the possible causes for this, and you should treat accordingly. Thank you. Thank you.
Thank you, Dr. Sunil. I think we are just going it with Dr. Sharath. One question for you, that you're just showing you the draining the fluid out of which is over the IOL.
Yeah.
Correct, no? So can we wait for some period or immediately you have to take them for surgery?
Yeah, it depends if it is a homogeneous fluid, not much obscuring the vision, patient is not symptomatic and all, you can wait. But if it is a turbid fluid and obscuring the vision, and if you're not sure whether it is an infective or inflammatory pathology, definitely you can remove it off.
Then how fast you do the, whenever there is a capsular distension syndrome, you do the YAG capsulotomy?
Yak capsulotomy is the last resort. See, the other thing is could be better to go into the AC and try to aspirate it as much as possible. Yak, the only disadvantage I told, suppose if it is an infective pathology, if you are suspecting little bit, if it enters into the PC, it may cause inflammation. That is the only concern. Otherwise, Yak is the simplest of the simple procedures.
Yeah, thank you so much, Dr. Sunil. Now we'll go ahead with the troubleshooting unhappy patient, which is associated with retinal pathology. So over to you, Dr. Sharath Hegde.
I thank AIS and Dr. Krishna Prasad Kudlu for giving this opportunity. So there is always a chance that few of the patients who undergo cataract surgery may be unhappy after the results. And finally, to find the cause of unhappiness, it will come to retina to see what it can be a condition is. Once the anterior segment, all the features are normal. So there are various conditions. Overall, any retinal condition can cause decreased vision, but majorly there can be two things. One, it can be subnormal vision, means even after the cataract surgery, the vision is not improved completely. It can be due to non-improvement of the vision, or the second thing is even after the cataract surgery, it immediately post-op vision was good, but after a few days the vision started deteriorating. The another condition is floaters. The way the patient will be complaining, a mosquito-like thing is moving in front of my every day. All those things can also be complaining can be there. So there are like any conditions, most of the conditions which can affect the retina can have these conditions. And the most important conditions to cause non-improvement of the vision is especially any condition which can cause your macular thickening, like diabetic macular edema or cystoid macular edema can lead to this. Like foveal thinnings post CRVO or CRAO, all those conditions, and any optic nerve involvement also we can see. And the most common condition to cause decreased vision after the cataract surgery few days later is post-op CME. I'll just touch upon these few conditions. So this patient who had underwent a cataract surgery 6 weeks before, vision was good 6.6, and after 6 weeks he complains he has a blurring of vision, and the vision was around 6.18 and N8. And when we saw that clinical, if you see the fovea, it looks not very much difference, looks normal, but there will be some amount of elevation which can be seen clinically in 3D version in indirect ophthalmoscopy. And definitely OCT will show you the presence of cystoid macular edema. So this is a case of post-op cystoid macular edema, which usually we see 4 to 6 weeks after the cataract surgery. If the patient has any intra-op complications or history of previous uveitis and diabetes, these patients have a high risk of development of post-op CMS. Usually, most of the patients, they resolve by 3 months, but nowadays we won't wait till the 3 months to resolve slowly. We prefer to give steroids, especially I try to give posterior subtenon steroid injection for these patients. If it is not improving or if it is retracting, then I go with anti-VEGF or Ozurdex implant inside the eye. Some people also give diflupredin eye drops also, which I said it improves better with that injection, with drops also. So this is the patient which I have given PST, and after the treatment, nicely the edema has resolved. The other most important condition nowadays has the diabetes is increasing, the diabetic macular edema. And cataract surgery has been shown that it is associated with the worsening of the diabetic macular edema after the cataract surgery. And there is approximately 22% of the patients can develop macular edema after their cataract surgery. So this is the one of the post cataract surgery patients, maybe patient having a total cataract or the retina may not be visible. Post cataract surgery, when their vision is less, when we saw her retina, she had a large diabetic macular edema. This is a study done by UK group where they showed us after the cataract surgery, the chances of development of DME sharply increases, especially if the patient has moderate to severe NPDRs. And this is another study done by Chen et al., where they showed post-cataract surgery, there was a statistically significant increase in the central involving diabetic macular edema. So this is the one case where a patient underwent cataract surgery, and after 2 weeks we can able to see the development of macular edema in the eye. So usually in these cases, what I prefer, if the patient has any moderate to severe NPDR with no macular edema or there is extrafoveal edema, I prefer to give anti-VEGF along with the cataract surgery. Similarly, if the patient has diabetic macular edema, always we treat the macular edema, then go for a cataract surgery. And if the patient has significant cataract, then usually I prefer intraocular implant or anti-VEGF 2 weeks before the cataract surgery. And before doing a surgery, we do an OCT and see whether the edema is decreased. If it is decreased, we go ahead with the cataract surgery. And maybe sometimes the patient may have PDR with traction, which may be missed, and it may be a reason for subnormal vision. And another important point which can be missed easily is ERMs. And there is some certain studies which showed ERM per se may not increase after the cataract surgery, but the edema or thickness, macular thickness can increase following the cataract surgery in the case of ERMs. If the vision is very abnormal, less than 618, or the patient is very asymptomatic, very symptomatic, saying lot of photopsias and all, then we go for a ERM peel. Another important which can be missed out is vitreomacular traction. Clinically, if you see, it may look normal, but there will be enhanced red reflex. The foveal reflex will be dull. And when we do an OCT, we can able to see a large traction which can be there. And sometimes these vitreomacular traction can progress into the macular hole after the cataract surgery. This is one patient who came with 18 vision before the cataract surgery, and 2 weeks after the cataract surgery, she came with 636 with a near vision of N12. And you can able to see in 3 weeks there is a progression of vitreomacular traction into a macular hole. This happens because the PVD can increase after the cataract surgery, and that has led to the macular hole. Or the patient may have pre-existing macular hole before doing a cataract surgeries. And the most common nowadays is the age-related macular degeneration. It can be wet age-related macular degeneration or a dry age-related macular degeneration. Most of the times it will be diagnosed before doing a cataract surgery. If the cataract is very significant or the mature cataracts, it may be missed. I advise usually before doing any cataract surgery, please do a preoperative OCT so that even if it is missed clinically, we can pick it out in the OCT. So this is the one study which showed whether after doing a cataract surgery, this ARMD changes progresses. Some patient may ask, because of the cataract surgery, the dry AMD has converted into wet AMD. But many studies have shown there is no correlation of a cataract surgery along with the progression of ARMD changes. There can be certain vein occlusion and causing the foveal thinnings. And sometimes these tributary vein occlusions can be missed out. And when you see clinically, if it is very difficult to identify, our FA can show you the capillary occlusions, and it will help us to identify the cause of decreased vision. Chronic CSRs, and the most important thing is the drug histories. So it's most important to ask the previous drug histories, because in this case you can see there is a bullseye like retinopathy, and it's something called as foveal reflex sign can be seen. This is due to the patient was taking HCQ tablets since many years, and this is the case of HCQ toxicity. And the dystrophies also can be there. The patient may not give a history of night blindness or any dystrophies, and they can have foveal thickening or thinning in these conditions. And if the retina is absolutely all right, then you should look on the optic nerve. The patient can have previous non-arthritic ischemic optic neuropathies or advanced glaucoma. The presence of opticociliary shunts over the disc may make you think the patient has old vein occlusions. Or there can be very rare conditions called white dot syndromes like azure and mutes and all, which can lead to decreased vision. This is the one case which is showing the optic disc pallor. And the most dreaded condition after the cataract surgery, nobody wants it, is post-op and offs. Acute, yes, everybody will get to know for early, but in the chronic conditions, like the patient will come with recurrent redness after 3 weeks, 4 weeks. Once you decrease the steroids, the patient will tell, my vision is decreasing, my eyes is redness, I am not happy. So always keep in mind these pigments, whitish pigments which is sitting behind the IOLs can be a pigments or chronic end of maybe a condition. This is another picture showing the fungal which has grown in the bag and come into the anterior segment. These conditions are very tricky to manage. Sometimes we may need to explant the IOLs. Recurrent uveitis, yes, most patients may come with recurrent uveitis, especially 1 in 400 patients can have recurrent uveitis, maybe because it is a sulcus placed IOL, or we see more commonly in a case patient who has diabetes, or patient is using any tamsulosin like tablets, or the patient has been used the pupillary hooks and all. Coming to just one few point on PVDs, if there is a recurrent floaters, make sure there is no lens fragment or there is no small fragments which is there sitting behind in the vitreous cavity. If it is a plain floaters, we can wait for a few time, or we can go for ag vitreolysis if it is more than 6 months, it is not resolving. But if you see a nucleus material, it's important to remove. Cortical material will decrease, but a nucleus material we may need to do vitrectomy to remove that. So take home message, the most important is to take the duration, how many days the vision is decreased and the previous treatment. Complete evaluation including RFPD has to be checked. Preoperative OCT for all the patient help to detect the retinal problems. If a mature cataract, please do ultrasound B scan to rule out any underlying retinal condition. And if anything which is not able to recognize, referral to the retina specialist also becomes important. Thank you.
Thank you, Dr. Sharath, for a very important talk. But one important slide I could able to observe about the recurrent redness. Patient comes with a recurrent redness. We always sometimes we have to keep it in mind about the endophthalmitis caused by the P acne. So patient coming with this P acne endophthalmitis normally it mislead us. So how exactly we treat, whether IOL exchange has to be done immediately or can we wait for a long period, especially to treat this patient?
It's all depending on the condition, how much is the severity of the endophthalmitis and where this pigments are, where this organism is sitting. If it is very much sequestered within the bag, we can try something called as injecting the intravitreal antibiotics within the bag. And washing the bag sometimes can also help you to decrease the condition, or intravitreal antibiotics also can help. If these conditions are not resolving, then only we go for IOL explantation.
Yeah.
Dr. Sunil?
Yeah, P acne endophthalmitis has various grades. If it is a mild form, probably it responds only to topical steroids and oral steroids. If it is a moderate, probably you may have to do a removal of plaque as well as giving an in the bag vancomycin, or sometimes do an ag and give an intravitreal vancomycin. If it doesn't respond to that, if it is a severe form of P acne, you have to do a capsulectomy with the cutter using a pars plana approach or something. So it depends upon the severity of that. The other thing, whatever the well-covered topics, points, Sharath, I would like to add is, whenever you are seeing a mature cataract or something in the pathology, please try to highlight and look the fundus of the other eye also, because many of the retinal pathologies could be bilateral. Like AMD, you can see some druseness in the other eye or something which gives a clue that this patient may have some pathology in the other eye also. So we can't just ignore by the B scan in a mature cataract, nothing is there. If you see any pathology in the other eye, try to explain to the patient, you may be having a similar thing in the other eye, and try to do OCT in most of the cases. Even if you find a slightest it could be dull foveal hystix or a few hard exudates or whatever may be that, try to do this thing, and try to do a peripheral examination also. It is beyond this topic, because many of the times we look at the central fundus, we tend to neglect many of the lattices and other things and all. So any of the post-operative complications which can occur because of either because of the obscuration of vision by the cataract or improper examination of the fundus evaluation. Sharath, what is your pseudophakic CME protocol when you would like to inject and when you would like to use the drops?
So most of the times, if I see a pseudophakic CME, I go for the injections. I won't wait till it aggressive. If the macular thickness is more than 300 or more than 320, I go for the posterior subtenos injection. I give like a transeptal injection, like how you give the block. I give 1 cc of tricot in this area, which usually they resolve by 1 month. If it is less than 300 microns, I give diflupred also 2 to 3 times a day for 1 month, and definitely IOP has to be checked regularly. And if still is not worsening, then I go do a FA to see really is it a post-op CME, or is it due to any other uveitis, or is there any other condition which is causing the macular edema. Based on that, I will think further the injection, whether I have to go for implant or the anti-VEGF.
A very valid point. See, don't be under the impression that posterior subtenons given always should be given in the posterior superior temporal quadrant, which many of may not be familiar with the techniques, and you may feel risk of globe perforation and other things. You can use a simple 26 gauge needle, give a peribulbar injection like that, like you give xylocaine, you can give that like that also. That is an alternative option, one thing. The other thing is, especially in diabetic macular edema associated with cataracts, please closely follow up the patients who have got a posterior capsular rent. Once the PC dehiscence occurs, invariably DME or diabetic macular edema progresses very fast because of the VEGF expression and the increased inflammation. So whenever there is an uneventful surgery in a diabetics, still can have an issue, but those who have got a PC rent and other things in a diabetic patient needs to be closely monitored than the uneventful surgery patients.
Thank you, Dr. Sunil, and thank all the co-instructor of this instruction course. It was very well attended. I thank all my friends and also the attendees to attend this instruction course. In the end, if anybody has got any question, we are open for discussion.
We once again thank all the delegates. Thank you. Thank you for your
Thank you.
patience.